Pleasure to introduce Dr. Jolive, Andrew Jolive today, who is Professor and Department Chair of Ethnic Studies, as well as the inaugural Founding Director of Native American and Indigenous Studies at UC San Diego. This program features a minor and graduate certificate in Native American and Indigenous Studies, and will also feature an Elder/Culture Bearer in Residence program. Dr. Jolive is a former professor and department chair of American Indian Studies at San Francisco State University and a senior Ford Foundation fellow. He is the author or editor of 9 books in print or forthcoming, including the Lammy Award nominated Indian Blood, HIV and Colonial Trauma in San Francisco's Two-Spirit Community. An enrolled member of the Atakapa Ishak Nation of Louisiana. He is his tribe's former tribal historian and is born of the Sunrise people of the Tisi Keep Huron clan. He is Louisiana Creole of Ishak, West African, French, Spanish, Italian, and Irish descent. Professor Jolive is a board president of the American Indian Cultural Center of San Francisco and the board chair of the Institute for Democratic Education and Culture, as well as the co-chair of the newly formed UC Ethnic Studies Council. A former Indigenous peoples representative to the United Nations Forum on HIV and the Law, he is active in both scholarship and community work. He currently serves as an advisory member with the UCLA American Indian Culture and the Research Journal, and as the series editor of Black Indigenous Futures and Speculations at Routledge, as a chief investigator with the Australian Research Council Centre of Excellence for Indigenous Futures, and as a scientific research mentor for the Indigenous HIV/AIDS Research Training Program at the Indigenous Wellness Research Institute at the University of Washington in Seattle. Please join me in welcoming Dr. Jolive.
Ruptures. Ripped from Earth's red skin, pinched, pulled, stretched out against time. Ruptures create soul wounds, wounds of 1,000 nations, of dissolved centers softening like wet cotton. All the scars slowly stain, slowly soak in. Ghosts haunt as we sleep, as we wake. No place for memory to hide, no place for memory to resolve, to resist. We are haunted, we are broken bone and ash. We are ancient mounds desecrated. We are contaminated water underneath ceremonial rock. We are two-spirit, we are between. Two-spirit dissolved, two-spirit names. Winkte, Nadlie, Namana, changing ones. Here in the cracks of earth, we emerge out of the wombs of dead mothers. Haunting spirits we become. Colonial haunting attaches and affixes itself to our children. Gone in the sun of 1,000 dancers, our spirit traumas remain. Invasion syndrome re-triggers every haunting, every trauma, every moment of settler violence. And yet here in this new morning light, beneath Spanish moss and eucalyptus, among smells of venison, salmon, and Koan, we begin a new fire so our people can eat, so our people can dance. Dance a dance only grandmother's feet recognize. We begin again, we sing again, we gather again. In ceremony, we wipe every frozen tear. In ceremony, we restitch every ruptured body, every ancestor memory. In ceremony, we return to our knowledge systems. We unmask our truths in multicolored blankets and shawls, exchanging skin, blood, and what's most radical about love, our vulnerability to become reborn. Here in our return, we reach out and whisper to the sacred. We hear you, we remember, we remain. We are ruptured no longer. We are dissolved no longer. We are rescinding every haunting, every rape, every unsober moment for a return to the sacred. Look there to the moon and see that the sacred is in the undilated pupils of your sisters, of your brothers. Look to the elders, turn to the youth, be your own healing, be your own truth, be your best medicine. There in the return may all sacrifices be remembered. May all hauntings be dismembered. May all ruptures dissipate into springs and creeks along the land where Indian blood, yes, Indian blood, means finally we are free, free to exist, free to love, free to remember. Finally, we are free. Yatol Wihokisakus, Andrew Jolive, Tisikip Opalusa Takapa Ishak Hiak the Ishak. Good afternoon, relatives. My name is Andrew Jolivet. I'm so honored to be with you today. Thank you for inviting me. I descend from the Tisikip Opalusa Huron clan of the Attakapaw Ishak of the Sunrise Peoples, born at the eastern side of the Attakapaw traditional homelands in Southwest Louisiana. I am the son of Annetta and Kenneth, grandson of Isabella and Andrew, Gertie and Howard, the great-grandson of Leela and Curtis, Eva and Edward, Rosina and Francois, and Allie and Eli. I was born in Yalamu, which is the traditional territory of the Ramaytush Ohlone in what is today called San Francisco. Today, I want to acknowledge the traditional unceded Kumeyaay territory at the man-made border, where many of us are studying and doing research and other work and living between what is known as San Diego and Mexico. I want to also recognize, acknowledge, and stand in kinship with the Indigenous peoples and the territories where you all may come from. So please feel free to acknowledge the Indigenous nations in the chat where you were born and raised, if not in this area. I put a link in the chat in case folks aren't sure. So feel free to share that and acknowledge. And I'd also, a lot of times we do these labor acknowledgements, and a lot of times in Native and Indigenous communities, we talk about the fact that we need to move beyond just, labor acknowledgements, land acknowledgements, and create meaningful partnerships, relationships. And I think when we think about HIV and AIDS and the notion of kinship, which I'll be talking about today, it's really about approach. It's about how we think about the work that we do. I also want to acknowledge the labor of Native and African peoples whose labor, forced labor, enslaved labor, including natives who were enslaved right here in California through the mission system, which were like plantations. I want to acknowledge the Black and Indigenous labor that built this nation. And also acknowledge today, the 19th, as we come toward the end of Native American Heritage Month. May the work be every day. This talk attends to the structural, global, and regional ramifications of settler colonial narratives and laws on the sociocultural factors that produce, enable, and maintain HIV risk within Indigenous communities. Taking from theorizations of post-traumatic invasion syndrome, or PTIS, what I talk about in my book, Indian Blood is Post-Traumatic Invasion Syndrome. In urban Indigenous communities, this talk asserts that HIV crisis and the resolution to that crisis must begin with movement away from individual to communal forms of healing, prevention, and disease management through the art of ceremony of an Indigenous kinship, as a radical methodology to increase Indigenous self-determination and transformative HIV interventions. So what do I mean by this, right? I'd like to suggest that when we think about when one goes to go see a doctor now, right, or find an HIV specialist or seek help for any health issue, they're basically walking into a strange institutional space. They're walking into a stranger's medical office and expected to feel comfortable telling these people the most intimate things about their life. This is what we need to change in terms of structure and ideology, and what I mean by sort of radical kinship and Indigenous approaches to healing and wellness. According to the Centers for Disease Control, the CDC, HIV/AIDS affects American Indians and Alaska Natives in ways that are not always obvious because of their small population size. Studies indicate that American Indians and Alaska Natives have seen a 63% annual diagnoses increase over the last decade among gay and bisexual men in the American Indian community. Stigma, poverty, high rates of sexually transmitted infections or STIs each contribute to ongoing HIV risk within this population. In order to fully understand the syndemics, right? Syndemics, the study of disease in urban areas and the intersecting factors that come with that, things like race, class, gender, that compound risk, right? The syndemics of AIDS within urban Indian communities as the epicenter of the crisis, we must analyze the impact of settler colonial narratives and laws that redefine, limit, and pervert Indigenous cultural practices and diverse gender behaviors in favor of Western colonial notions of normative behavior, right? What were some of the earliest kind of campaigns in communities? Just wrap it up, or stay safe, right? Some of the language that people use out in community, we can see with COVID again, mask up, right? Wear a condom, as opposed to thinking about what is it that we can do collectively rather than blaming individuals or saying people are doing something that's wrong, right? Scholars like Karina Walters, Choctaw, and Linda Tewai Smith, Maori, have written extensively about the impact of using Indigenous-centered programs and methods for combating health and educational disparities. American Indians and Alaska Natives have the third highest rates of infection after African Americans and Latinos. According to the CDC, at least 75% of HIV infection cases in the Native community involve men who have sex with men. Right there, I'll pause, even though I've written that, right? Even these categories that we use, men who have sex with men, we have to be very specific about who we're talking about. And so sometimes that leads to some confusion, right? These categories that we create instead of allowing for self-identification. The CDC identifies several factors specific to American Indian communities that increase the chances of seroconversion, the threshold at which an antibody becomes detectable in the blood, confirming a change in viral infection status from negative to positive. American Indians have the second highest rate of STIs among all ethnic groups. Having an STI, as I'm sure all of you know, increases susceptibility to HIV infection. American Indians have higher poverty rates, complete fewer years of education, are younger, are less likely to be employed, and have lower rates of health insurance. All of these are the results of settler violence, which I was talking about earlier, colonial violence that has told Indigenous people, you don't belong, you don't fit here, you are aberrant, you need to change something about yourself. So how we talk, how we communicate, how we help folks to feel safe when they're seeking treatment or just need help, right? I talk about with Native communities I've worked with that we need to move away from even ideas. I was working with the Native American Health Center in Oakland, California, and they have a conference they do for Native youth called Culture is Prevention. And I said, well, maybe we should think about culture as medicine, right? That it's always not always about sort of looking at sort of reactive, right? That even thinking like being very proactive about it is centering our own knowledge systems, our own sense of wellness practices to do well, right? And so each of these different factors, right, limits American Indian and Native Alaskan access to high quality healthcare, housing, and prevention education. High rates of alcohol and drug use, as we know, as with many other groups, can lead to sexual behaviors associated with increased risk for infection. HIV intervention models in Indigenous communities, though, must recenter tribally specific as well as urban Indian regionally specific kinship models, right? Create mentorship programs or what I call it, cross-generationally, right? Because I think what we're seeing, and from my research, what I've seen too in urban spaces where now 85, 90, almost 90% of the American Indian population is now in urban areas, not on the reservation. Yet most of this health services are done through IHS, Indian Health Services, or urban Indian health clinics. There's about 35 of them across the country, but they're closer to reservations because this is tied to federal recognition status. So one of the challenges, I think, right, is how do we support Native folks in urban areas when those centers aren't necessarily located there? So if we aim to deal with global issues such as the AIDS crisis or other health issues like COVID that disproportionately impact Indigenous peoples, turning to more local, specific, and applied interventions that speak directly to the needs and concerns of Indigenous communities must be placed outside the theoretical canon that does not necessarily serve the interests or daily lived experiences of American Indians and Alaska Natives in the United States. A concept I talk about quite a bit, two-spirit cultural dissolution, is a major aspect of what I term post-traumatic invasion syndrome, or PTIS, which I mentioned above. By using the word post, I am in no way suggesting that the process is over, but the specific event of invasion has taken place, and its ongoing impacts can be witnessed through an enduring legacy of trauma, weakened stress coping mechanisms, and poor health outcomes in Native communities as a result of deeply embedded structural systems of racism in settler colonial healthcare systems. So how do we change healthcare systems to actually address this long history of mistrust, right? The poem I opened with, Ruptures. So this idea of PTIS and then two-spirit cultural dissolution is that during colonial contact, everyone from missionaries to health officials to government, military, all that sought to destroy and vanquish Native and Indigenous peoples and change their ways of knowing themselves, right? And so how we think of ourselves, right? The idea of two-spirit, right? The person who is neither male nor female, that they are a third or fourth gender, but that this is not the same even as when we think in contemporary context of someone who might identify as transgender or even gender nonconforming. A two-spirit person held a particular cultural role because they were seen as being closer to the creator because they were neither of these other two sort of embodiments of gender identity. So these traumatic invasion and post-invasion experiences continue to threaten the well-being of two-spirit and queer American Indians, whose racial, gender, and sexual diversity make them one of the most marginalized groups in the United States. Because of their diversity and their perceived lack of authenticity, many contemporary two-spirit natives are left isolated and looking for community support networks that will accept them for who they are, regardless of their racial identification, or whether they identify as queer, transgender, or some other category. In 2015, though, something remarkable happened. Lakota medicine man Richard Dickey Camp led a ceremony of return, it's called, the healing the broken spirit, bringing back the two-spirit, or the Wichapi Koyakta Tiosipa, for members of the San Francisco American Indian community, to welcome two spirits back into the community and to offer them an apology for their treatment over the past centuries as a result of settler violence and colonialism. You see, when Native peoples took on, right, the ideas of colonizers, two spirits no longer held this special role, right? They would become ostracized. The same ideas that mainstream Western society has held about, say, LGBTQ folks became internalized within tribes, right? And so even your own home communities were no longer these spaces for communal wellness or support networks, right? Not entirely, right? And so Healing the Broken Spirit was held in Oakland, California at the American Indian Friendship House, and it included a feed, which is everyone comes together and brings food. There was music, and most importantly, prayers and wishes for reconciliation. The ceremony is significant because it provided two-spirit and LGBTQ identified natives with an opportunity to heal in very culturally specific ways and through kinship or collective wellness rather than individual systems of care. They came together as a group to talk about their mutual sort of experiences. And I think that's really important. And so as I discussed earlier, two-spirit cultural dissolution creates ruptures in the social, psychological, and political mechanisms of community support. Healing the Broken Spirit not only acknowledges these cultural ruptures, the ceremony also includes an apology from the broader Native American community for the many years of exclusion that two-spirit members have endured. The distribution of the AIDS crisis in global context is often explained by ongoing stigma and silence. Healing the Broken Spirit intentionally seeks to address and silence issues around shaming in order to restore balance between all members of this particular community. So while I have argued that we must look at HIV and the art of healing from a communal level of understanding, and even what I would talk about, or Metzel talks about, is structural competency as opposed to cultural competency. Really, this all means too that we have to move away from trauma-informed systems of care to hope-centered ones, right? Because no one wants the center of their experience to be about damage, right? And so I also want to underscore the very real personal impact of this disease and how my own story as a professional and a researcher was impeded by a medical system that blames the individual while failing to acknowledge how racial bias and homophobia continue to plague a best practices kinship approach for supporting health and wellness within Indigenous communities. I thus want to intentionally offer a personal narrative to support critiques of medical systems, medical apartheid. Some of you maybe have seen recent articles about Doctors Without Borders, right? And some of the things that they're facing right now is related to race issues. I think there's a long history I've found where I am in the Department of Ethnic Studies. I've worked in Native Studies. Sometimes we don't talk to each other, right? Medical isn't talking to the folks who do work around race issues. The folks who are doing race issues aren't talking to the folks who are doing medical stuff all the time. We need more of that interdisciplinary kind of work. My own entrance into the world of HIV/AIDS begins from a place of trying to understand what healing means and how kinship practices can successfully address HIV/AIDS in Indigenous communities. As a mixed blood Afro-Latin, French Creole, French Black, West African American Indian, Opelousas Takapa Ishak, Spanish, Italian, and Irish researcher, the experiences of two-spirit, gay, transgender, bisexual, and queer people resonate within my own life experiences in profound ways. In my previous research, I've argued that the concept of radical love can support a healthy process for addressing trauma and risks associated with the syndemics of HIV/AIDS. Radical love asserts that as community members from the same ethnic group come together to share their experiences and vulnerabilities, they open up a space for transitioning from individual to collective wellness. My own journey toward healing was deeply impacted by a need not only for cultural understanding and competency, but to transform how we actually address in everyday and practical ways the unequal treatment of Indigenous peoples within settler colonial nation states like the United States. I see my work as something that must demonstrate integrity and relational accountability. In fact, a key component in addressing issues of structural competency depends upon researcher self-reflection and responsiveness. I came to the question of HIV and AIDS and questions of public health and queer theory relatively later in life. I was trained as a sociologist. I was actually not doing public health work whatsoever. I was doing, racial formation theory. And so I came to these questions from that vantage point. In the spring of 2003, I was preparing to leave my position as the Dean of Middle School Students and Multi-Programs at Presidio Hill School in San Francisco. At that time, two professors in the biology department at San Francisco State, who are the grandparents of one of my students at this school, they asked me, Andrew, would you consider teaching a course on people of color and AIDS that had been around for several years and no one had taught it for a number of years? And I said, sure. We were out actually just talking, and I said, sure, that sounds interesting. I'd be up for it. Developing this course as a mixed race person or with a mixed race studies background allowed me to understand that there was an aspect of the epidemic that no one was also really talking about in the academic literature, right? The overrepresentation also of young men who are two or more races in those counts, right? So I think another important thing to think about is even, when we think about who is American Indian, we're severely undercounted because people don't know, right? They have the stereotype of who they expect to see. They might see someone come in with red hair and blue eyes and they don't know, or brown skin and an afro, or long hair and braids. We can't make assumptions, right? So in the fall of 2002, as I said, I was the Dean of Students and Multicultural Programs at PHS, and I was lecturing at San Francisco State University. And I was also finishing up my dissertation at the University of California at Santa Cruz. I was busy and in many ways on top of the world. In early October of that year, I was feeling a little bit of a flu bug and started to have this terrible cough that just would not go away. And I was like, what's going on? I didn't think much of it until one afternoon when I was walking up the hill from Julius Kahn Park in San Francisco with some of my middle school students. I couldn't breathe. But like so many of us often do, I ignored my breathing problems and chalked it up to the flu. On Wednesday, October 8th, I went in to see the doctor, and he told me it looked like I had a bad case of asthma. So I went home with inhalers in hand, and the doctor told me he would call me by that Friday. So this was 2 days later, right, that they'd call, if anything showed up in my x-rays. He didn't call, so I assumed that everything was fine. And that Friday, as I began to breathe less and less and develop a fever, I decided that I should just take the day off. I was never one to get a cold very often, and when I did, it never lasted very long. I also hate taking off from work, but this time my body seemed to do the deciding for me. I stayed over at my parents' home that afternoon, and by Sunday, with my parents urging, I considered going to the doctor again. It was about midnight Sunday when I called my sister and I told her that I changed my mind. I said, I really needed her to take me to the emergency room. I couldn't breathe in a resting position. Once we were at Kaiser's emergency room, I felt much better and I thought, I should have just stayed home. I feel fine. They're going to think I'm wasting their time. So as the nurse took my temperature, I fully expected to be going home. I was wrong. My temperature was 102 or 103, and my oxygen level was 87. She informed me that I was a very sick man. As I lay in a bed waiting for x-ray results, and notice, right, that I never got this call back. Here it is Sunday, and I've been misdiagnosed potentially, right? With these kind of oxygen levels and them needing to look at my lungs more closely. So as I lay in bed waiting for these results, a doctor suddenly emerged and said he had some questions for me. Or excuse me, she said, this was a female doctor, this was still that evening. She proceeded to tell me that they had got the x-rays back, and she said, you have pneumonia and it's on the front and back of your lungs. That's something, she said, we only usually see in elderly people and in people with HIV. My throat dropped in my stomach. She then rattled off several questions. When was the last time you had an HIV test? Have you had sex with men? Can we give you an HIV/AIDS test? The room seemed to get very small. It also seemed to be moving ever so slowly until it was spinning. I looked at my sister and wondered, what was this all about? Neither of us discussed HIV. I just shared with her what the doctor had said and informed her that I had had a test when I started dating my ex-boyfriend in 1998. It was negative, as were previous tests, and because I had only been with him and had only recently broken up with him, there was no way I could be HIV positive. I was confident, and my declaration to my sister made me even more confident. I could hear myself speaking the words out loud. I was never promiscuous. We were monogamous, and I was negative when I started dating him. So how could I have it? How could I have it? Notice the judgment. This is surely a question many living with HIV and AIDS must ask at one time or another. I was shortly informed after consenting to the HIV test that I would have to stay in the hospital overnight because of my oxygen level. It was a very sleepless night. I can remember people coming in and out of the room. I was waiting for tests, trying to find out if I had a walking form of pneumonia, which is, common to a lot of folks, or if I had PCP, pneumocystis, which was pretty much the number one killer early on in the HIV/AIDS epidemic. This opportunistic form of pneumonia. So later that morning, and I remember the Giants had been playing, and I was watching all these baseball games. I think it was raining that next day in the morning, and a doctor came into my room and said, "Can you please turn off the television?" He said that, we have your results. The doctor remarked. He said, "I'm afraid it's positive. You have HIV, and we've already begun treating you for the PCP, the pneumocystis. But the only way we can confirm the PCP is by giving you a bronchoscopy." I stopped. My ears began to swell. My stomach knotted as he talked, and it was like I couldn't hear him anymore. I started thinking about my parents, about my brothers and my sister, and about my students at Presidio Hill School. I held firm as the doctor told me, quote, "I have a friend who recently went through the same thing. Things are different. You can live a long time with the disease. We've been able to treat this as a chronic illness and not a terminal death sentence." He asked me if I had any questions. I insisted that this was impossible, and that I was recently tested, and that the only person I had been with since that negative test, since was also negative as well. So I was like, what does all this mean? He said, there are two things we look to monitor your progress, which many of you will already know this, of course, obviously, your CD4, your T cell count, and your viral load. I didn't know it at the time. I knew about T cells, right? So of course, I'm considering myself somewhat educated here, right? Working on a doctorate, and I honestly wasn't really sure what he was talking about. I knew about T cells, but I didn't know what he meant by viral load. So once I snapped out of it, I asked him what was my count. He told me I had 35 T cells. I asked him what was normal, and then of course he responded, around 500 to 1800 is normal generally. Anytime you have less than 200 T cells, you become vulnerable for the opportunistic infections. And the CDC defines AIDS as anyone who has or ever has had less than 200 T cells. So I have AIDS? I asked. The doctor responded in the affirmative, yes, you do. And then the doctor proceeded to tell me that my viral load was over 500,000 copies per milliliter of blood. Right. So I'm very sick here, right? I'm thinking I'm really close to death actually already. And if it wasn't for Septra, the medicine that they gave me, which I actually turned out to be allergic to, that saved my life, I wouldn't be here before you today. Is there anyone you can call? He asked. I bite back my tears. He told me they were going to run some more tests and that he would be back to see me. I thanked him, and no sooner than the door shut, I let out a yelp and the hot tears started streaming down my face. I was so overwhelmed by grief, I felt cold and so alone. I picked up the receiver and I called my Uncle Charlie. I was too afraid to call my parents first. They would be devastated. And the only thing, that would be worse, I thought at the time, than dying was hurting them. He picked up and I gave him the news. I burst out crying and I could not really talk to my uncle. I decided to call him because he worked in hospice at the time with cancer and AIDS patients, and because he had been out since he was 15 years old. But I mostly called my gay uncle, right? We all have a gay uncle, because he would understand that this was not inevitable, as so many parents sometimes tell their children when they first come out. He listened, comforted me, and said that he would be right there, and that until they could positively confirm the PCP, they could not tell me that I had AIDS. That gave me a little bit of hope. I hung up the phone and could not contain the tears. I imagined dying and never seeing my brothers, my sisters, my parents, or students again. Nobody wants to see their teacher die. Nobody wants to see their child die. It's something that I would repeat as I dealt with the news and shared it with family and friends over, the following weeks and months and years with you today. After being released from the hospital a few days later and 25 pounds lighter, I went to stay with my parents. I'd already told my dad and my mom. My dad had suspected AIDS all along when my cough wouldn't go away for all those months. Before leaving the hospital, I had so many conversations, so many tests and needles poked at me. I was terrified, but perhaps not as terrified as some of my nurse providers, who were noticeably careful, but also noticeably afraid to touch me. As I awakened one night for blood test, I heard the nurses talking in what I think was Russian, and I knew that they were saying, "Be careful, he had AIDS." I had already heard this once earlier that day. It was tough once I was released from the hospital, not knowing what to do or what would happen. Would I finish my PhD? Would I ever work again? How long did I have? And how did this happen to me? After about 3 weeks, I decided I needed to see my kids. So I went to Halloween at the school, appropriately dressed as a medical doctor. It was good to see them. It gave me hope. It gave me energy. I decided I had to go back to work. It was scary. Like I said, I had spent those 3 weeks going back and forth to doctors, thinking I had liver failure because of the allergy to the Septra. And disclosing my HIV/AIDS status to my friends and siblings was very hard because, maybe the hardest thing I've ever had to do, because I just didn't know how people would react. I blame myself and I didn't know how they would react to me. So, I found myself thinking, same thing I think when I came out first, when I was 19, 20, 21. Was God punishing me? Is this what I get? Is this what I deserve for being gay? And I wonder how many other American Indian Indigenous people think, is this my fault? How many patients you might see with cancer or just a urinary tract infection even, right? Is this my fault? What did I do? They need people to take a minute with them and not be in a rush to get to see the next person, to not feel like it's all about business. This is what I mean about kinship. So every time I would see my two younger brothers and my older sister talking and laughing, I started to think one day, I might not be here to hear their laughter, to share in the jokes, to see their children grow up. My family and friends were so good to me during that time that it really taught me to slow down in terms of work And it also taught me to put myself first a little more often. I went back to work early in November and began my antiviral medications, as well as medicine for the PCP, which I said, was confirmed. No sooner than I had returned to work, I got sick again, just like crash. It was hard missing school and work. I had only told a few people at work about my status. After dealing with being sick for another 2 weeks in December of that year, so this was 19 years ago, this almost this month coming up, I went back to work part-time in January and started finishing my dissertation. I thought, if I'm going to die, I'm going to finish what I started first. So I worked with a sense of urgency. I sent my dissertation into my committee that January and graduated in March of 2003. Slowly, I started putting my life back together. It was hard. I lived by myself. I had just broken up with my partner of almost 4 years a few months prior to my diagnosis. Turned out he was positive too. I wondered if had I infected him somehow. My doctor told me advanced HIV takes at least 10 years to develop to that stage I was at. But as far as I knew, this could not be possible because I wasn't sexually active at 17. It was very hard as I pause and kind of reflect. And I've shared this story before, but not the intimate details as in a long time. My doctor had, basically said this took a long time, and I just really struggled to figure out, how did this happen? Eventually, these questions dissipated, and I had no choice but to move on. I got my first lab results back that January. So this is about after a month and a half on the meds. My viral load dropped. It was 1,200, and then later became undetectable. And my CD4 count, it went from 35 to 411, only after a month and a half on meds. My numbers, however, would go up and down after this. I will tell you that today it's undetectable, and over 1,000 is my T cell count. But it was a card I received in the mail from my Uncle Charlie after those first results that gave me the hope to keep living. He wrote on the inside, quote, "God is everywhere, even beneath the wings of a dove. Congratulations on your good health. Love, Uncle Charlie." I think about that all the people around us, right? Maybe whether we're religious or not, he said God, our creator, but the idea of the dove, right, being a relative, but also that all of us can help one another when we are struggling and feel defeated because we know our mental state is so important. I finally decided that this was not a death sentence, but the next big obstacle for me was learning to cope with my status and the issue of love. All I ever really wanted was to find love and have my own family. This seemed impossible now. Who would want me? How would I tell anyone I met that I was positive? Right before I got sick, I had met a nice guy from Lebanon. But once he found out why I had not called him and that I had been in the hospital, I never heard from him again. My confidence and self-esteem around disclosure and dating were really low. I share this to personalize and think about every patient you may see has a story, right? Whether they're positive or negative, whether they're just coming in to talk to you about PrEP or anything, they have a story. I had thought about getting back together with my ex, figured that was, self-destructive and for the wrong reasons. Since my diagnosis in 2002, I've had several very loving relationships, and most important, these relationships helped me cope with HIV and AIDS, and I found that within community. And I share my own personal story at length here to provide a mirror into the questions, struggles, pathways to wellness for Indigenous people. Community wellness approaches in Native American communities must also consider the diversity of experiences. What tribe are people from? Not all Native people are the same. Not all Black folks are the same, ranging from rural and reservation life to urban living. I also share my own story here because it is an example of the stigma that HIV and AIDS can have on members of Native communities. For all the resources and advanced education I had at the time of my diagnosis, so all this idea of just it's all about prevention was never the right track, right? I think it was about the kind of support, the kind of active listening. Creator gave us 2 eyes, 2 ears, and 1 mouth for a reason, right? So look and listen first before speaking. So it was not until I was actually engaged in ceremony that I was able to truly begin a process of healing. A few months after my release from the hospital, friends in the community organized a pipe ceremony for me with a mutual friend of ours, Daniel Freeland, who was a medicine person from the Navajo Nation. He's since walked on, passed away. I can still hear Dan's words that day. Quote, "You can't think of yourself as sick, Andrew. A lot of people are going through what you're going through. They can't tell their stories. You can share your story, and in doing that, you can begin to heal yourself, and you can also help with the healing of your communities so that others will know that this is part of the cycle, the life cycle of challenges we face to make us stronger." He went on to say, "Sharing your voice and your story can be its own form of ceremony because each of us shares our story, right? And when we do that," he said, "we help someone else to feel stronger and more connected. We become medicine. When we share our pain and in becoming that medicine and creating ceremony, you become your own medicine, and your brothers and sisters also become your best medicine." So it is often hard to explain how ceremony can be medicine and vice versa. However, in my own experience as a queer, two-spirit, mixed race, Native, Creole, Black, Latinx man, medicine means making use of something that will make us feel better. Sharing our painful stories through what I have termed radical love means that we can only understand medicine and ceremony when we open up and release all the stigma and emotional and physical suffering that we are experiencing. We must also acknowledge how these experiences differ from region to region, person to person, while respecting the fact that the differences are also what make Indigenous communities stronger. May you work with Indigenous communities with an understanding of the importance of kinship, of community, and radical healing through radical love. May you think of your own practice not as work, but as ceremony. Iwe Omezi, thank you very much.
Thank you so much, Dr. Jolive. That was truly profound. Does anyone have any questions for our speaker today?
I think we've met before, Andrew, through Bonnie Duran in the iHeart program, but thank you. Really appreciate you sharing your work with us today. This is some work that I've been involved in too for a couple of years now, probably since the early 2010s, but really appreciate you diving into not only the heterogeneity that exists for American Indians, Alaska Natives, as well as all other racial ethnic groups, but also this need to focus less on a deficit approach and more on a strength-based approach. This is something that the communities I work with here in Southern California have asked for us to do. They're tired of us coming to them with research questions of how can we solve a problem, instead of looking at what's working in our community and how can we uplift that. So I was wondering if you could just comment more on your work from the HIV world in terms of taking that strength-based approach, looking at those upstream factors rather than just looking at those downstream deficit factors.
No, thank you. And it's good to see you. Yeah, no, I mean, actually, Bonnie, who I don't know if you know, Bonnie and I are cousins. I learned from her and Karina. These are colleagues of ours for the folks that work at the University of Washington. I actually mentioned Karina at the outset of the paper, and she's been a leading figure for, I don't know, over 20 years on HIV/AIDS research and Native communities and a number of other public health issues, and as Bonnie has as well. I learned from them, I think, and also Nina Wallerstein, who does community-based participatory kind of action research at University of New Mexico. And I've learned even more since then, right? But that I think we need to ask, like you said, we can't go to communities with the questions. We have to ask them what they need, I think, and we also have to ask permission to even be there, even if it's our own tribes, for example, if we're a member, that we have to ask permission. And some of the ways I've seen this happen, so the work I was doing in San Francisco with the Native American AIDS Project for a couple of years, we designed and created a peer mentoring program across generations. Because what I learned in listening to the community was, first of all, the focus groups became a healing space themselves as we were sharing. So when I was talking about radical love, when we would, that came out of that work too, is I was noticing, I said, wow, we're having meals together, we're praying before we start, we're telling stories, even though sometimes we're crying, we're also laughing. And we're walking out like with a community behind us. But so many of the people that I talked to in their stories, they were saying as they left maybe their various communities, some maybe they had already come because their parents had relocated, but others maybe had come recently. And they said either a lot of them, because the focus was on mixed race Native folks, but that they were looking for communities. Even folks who grew up and were enrolled and everything, they still were kind of coming to these places and like, I can't find community. And so what I talk about in the book and where I see that strength base is in like organizations that are culturally specific, I think are really important resources. So when you have a Native American health center in an urban area like San Diego or like Oakland or Seattle or Chicago, they're really important that we actually are using the best of all the knowledge that we all have and hold, and that we have to remember that the community are the best experts and what kind of issues are happening. Something that might not look obvious at first, or might not make sense at first at all, may become clear later. I remember actually Karina, in fact, telling a story. This is actually about diabetes, but she was talking about why are the kids are so, what's going on? And she said some of the elder women in the tribe explained to her, they said, well, when they had went on the walk, right, during removal, and everyone didn't have enough, I mean, kids were so small, it was intergenerational. It got passed down, this idea that if you look too thin, you're maybe either poor or you're in bad health or something like that. And so of course they'd be like, eat more, eat more, eat more, right? I think you saw these kinds of things in Native communities. I remember a dear mentor of mine, Michael Sosi, who's also Navajo in Colorado River. He's also passed on, and just want to acknowledge him and Dan again as well, who are important people and figures in my life. And I remember Mike talking about the 80s and 90s. He was a bit older than me and saw a different phase of that period. And he would say, yeah, Andrew said, people are all, that's why gay men now, there's a big thing about the gym, right? Everybody pumping up. I think about our self-concept. And so I think that self-concept, why it's so important to center the strength space, is to say, what are the good things, right? To focus, to try to center those good things that, are part of our experiences. And that can be really hard. Like, and one thing I didn't say was I've been sharing my story even and doing that. Like some of the folks we're talking about, it's difficult because a lot of the folks that were involved in that project and that are in, Native communities, unfortunately, it varies. Again, I don't want to paint a particular picture because it gets played too much, but they're marginally housed, right? Folks don't have cell phones, or if they do, their numbers are changing. Like, maybe it was a temporary phone. So I think, again, I guess the best thing is we have to have a lot of humility. Whether it's whether we're working Latinx communities or we're Latinx, we have to, our Filipino communities, we have to have a lot of humility when we talk to our communities, because they do know, they really, and know that they know. And sometimes it's hard because we get stuck in these kind of patterns that really have not even been of our own choosing or design. So thank you.
I just want to acknowledge that there was a comment in the chat from Katie Riggs. Thank you so much. That was such an important message, both for reinvigorating our reasons for being in this field and new perspectives. I especially appreciate your message about moving beyond trauma-informed care. I also wanted to make a note of that as well. That really resonated with me. Your suggestion to just move away from that label in our approach. And was it, you said hope-informed care or hope-centered care?
Yes.
And I think that it's somewhat strange that we don't approach it that way already. It seems sort of obvious that when we're thinking about trying to, you know, help people navigate those sorts of experiences, that they probably may not want to label it that way. So I really appreciated that comment. And you know, it's probably something that we should start to institute moving forward when we use that phrase.
Yeah, no, I think absolutely. I mean, I think for so long, people want to see positive images. And so and to go back to even Tommy's, Dr. Gaines' question, in working with the American Indian Cultural Center in San Francisco, just having space for young folks to express themselves, a basketball league, so they have something to do, or a beading class, so folks have a sense of community. That's also the other aspect of kinship, and that's for all kind of wellness things. I remember talking with folks from the American Heart Association who are trying to do work with Native communities, and we're looking for advisors and things like that, and talking to them about some of the things. It's just about trying to understand, and again, just not making I think assumptions, and being really clear about that we have to place at the center. When people say they're patient-centered, for example, what does that actually look like? What does that mean? I think it's asking. Again, we really have to ask and not assume or tell people. So I was probably sounding a little distracted too, because I was looking for the citation for the Sean Jenwright thing on moving from trauma-informed to hope-centered. So the link's in the chat. Yeah.
That's great. Thank you so much for sharing that. Any other thoughts or questions for Dr. Jolivet? So I think we're coming up on time. On behalf of HIV Institute and San Diego CFAR and the UCSD CFAR community, we really want to thank you again so much for speaking with us today, and also sharing your story.
Thank you, Iweo Mizi. Thank you so much. Yeah, have a good afternoon and a good weekend. Be safe. Be well.
Thank you. Thanks, everyone.
Bye.
Thank you. Thank you very much, Eileen.
Thank you.